Hello?
Hi, Dania. Can you hear me?
Yeah. I think that works.
Hello, Dania.
Hiya. Hi, can you hear me? Hello? Hello? Hello?
Hi, I've uploaded the slides. Can you see them?
Yeah, I can see them. Thank you. Yeah.
Yeah. Okay. Thank you. So I've also started recording. So whenever you're ready, feel free to start.
Yeah, sure. Just one question. Will the
Yes.
session be interactive or?
There is a chat that people can put comments in. So I think we have 5 other people here at the moment,
Mm.
so they can, if you ask questions, they can put their answers into the chat,
Okay, because I've
and they can
made
ask
it
you
like
questions.
a case-based discussion. So if they,
Okay.
okay, so we'll see how it works. No worries.
Yes.
Okay,
All right.
thank you.
Okay.
Thanks. Okay.
Thank you.
So let's start. So today we're going to talk about thyroid pathology from benign to malignant and try to make a clinical and pathological correlation. I feel like in med school or in like as a junior doctor, we don't get really exposed to the pathological features or how does it look like that on histology. So here just we want to make the space between the clinical and pathological features a little bit more closer. So just a closer look. Um, at the end of this session, I would like you to recognize the normal thyroid structure in histology, recognize common benign thyroid conditions, distinguishing benign from malignant thyroid, and maybe just outline the main types of thyroid carcinoma and how they look like on histology. So the normal thyroid, the good thing about thyroid histology that it's very, very distinctive. Like nothing in the body looks like the thyroid. So whenever you see these like spaces, like these follicles, pinkish, like circles, varies in size, you would know that you are looking at the thyroid. So the thyroid it consists of follicles lined by cuboidal epithelium. You can't see the epithelium from here, but it can be when the follicle itself can be a little bit like macro follicle or large. It can be flattened, but mostly it should be like a cuboidal type of epithelium. There is, and it is also filled with this material. So this is the colloid. So you can see here that it is a pinkish material. So these are colloid, and between these follicles, so there is the parafollicular cells, or what they are called now C cells, and they produce the calcitonin. So these cells here, the follicular cells, they produce the hormones that we already know, like the T3 and T4, which are the functioning hormone of the thyroid. And these cells here that you can't see from this power, they secrete the calcitonin, which we will discuss later. Um, it's important to say that between these follicles, you can see that these follicles varies in size. So there's like a large follicle here, there's a smaller one here, and that's a good thing in thyroid. Like you don't want stuff to be very monotonous or like they look very much alike. So because you might think that there's something like neoplastic going on, but the variety and architecture, it's very let's say like like calming feature in thyroid. You can see here that there is a lot of blood vessels. It's a very vascular organ, and the stroma itself can have some fibrosis. It depends on the age of the patient, how and also like all these predisposing predisposing features, like maybe exposing to to radiation, or all these kind of, or infection, or all these kind of like risk factors. So so this is a closer look to the thyroid follicle. You can see here that this is the cuboidal follicular cells, and this is the colloid. And you can see here this cell, which look a bit more pinkish, if like the pinkish cytoplasm, pinkish than this one. So this is what we were saying about, which is the C cells. Okay, so it's the parafollicular cells. And you can see here that there's like a red blood cells in between, which these are just vascular spaces. These are just like small vessels. And this is the pinkish material here is the colloid. Okay, so this presentation is a case-based presentation. So I'm gonna present a case, and then you're just gonna, if you don't mind participating, that would be like amazing. It's not about testing your knowledge or anything, because I know that this is like a very far topic from what we study in med school. But I mean, if you have just to make it like more interactive, so if you don't mind scanning this barcode, and this and it will appear like a question, and I will ask the question, and if you can choose the answer, and then we can discuss. It doesn't have to be right. It's just like to be more interactive. So this is the barcode. I'm just gonna stay here for a few seconds if you can scan it, and if anybody like in the can say in the chat that they are able to enter and see the questions, that will be good. Yeah. So first question.
I'm sorry,
Yeah.
Dania. I just wondered, there's a question in the chat about what is the white space in
Oh,
between,
sorry.
I think on the
Sorry,
previous
I can't see
image.
the chat box. I'm so sorry.
Oh, that's okay.
Okay,
That's
let's go
okay.
back.
Um, yeah, it's just about that image.
Yeah.
Someone's asked about the white spaces in between. I think in between on the picture.
Um,
Asking what they are.
I'm not sure what spaces there. These are the spaces that we're talking about. These things.
I'm assuming so.
Okay. So this is really nice that you mentioned that. So when the thyroid is, and also we're gonna discuss it later, but when the thyroid is active, they do something called scalloping of the colloid. So this is like a scalloping. It's like an empty space, because the thyroid is active. So, and we see these things more often. Like this is in a normal thyroid, but we see these more often in the hyperthyroidism cases, where like in Graves' disease, where all these colloid would have like these empty spaces, which means that the thyroid is hyperactive and secreting a lot of hormones. Thank you.
Okay, thank you.
So let's start with case number 1. So enlarged firm thyroid with lymphoid follicles, germinal centers, Hertel cells, and follicular atrophy. So just like put whatever comes into your mind. So I'm gonna just stay for maybe just a bit, and then we'll answer. See if there's anyone answering. It's okay if it's too much from the start. That's my bad. Okay, so we're just gonna explain anyway. But at any point, if anyone wants to participate, you're most more than welcome. Okay, so enlarged firm thyroid with lymphoid follicle, germinal centers, and Hurthle cells, and follicular atrophy. Uh, let's go and see that picture. Okay, so this is, I'm just gonna keep putting the normal thyroid so you can appreciate the difference. Okay, so this is the normal thyroid. Okay, and this is the abnormal thyroid. If you can see, just like if you can participate and even like put in the chat, like what is the difference between these two pictures? If you can see maybe just like a blue dots or anything, that would be good for me. So, okay, so one of the people saying it should be Graves' disease, which is actually one of the possibilities. So that's really good thought. So let's look at this picture. If you can see here that there are some lymphoid follicles here, comparing to these, yeah. The cells here look a bit pale, if that makes sense. Like not like these cells. Here they look more blue. So they look more eosinophilic, like pinkish. Yes, exactly. Lots of inflammatory cells. Exactly. There's a lot of inflammatory cells here. Yeah. So, without going into deep, I'm going to discuss more of the features, but let's say first what is that? So this is Hashimoto thyroiditis. It is an autoimmune disease. It presents with goiter, elevating circulating antithyroid antibody. So what happens in Hashimoto? So it is an autoimmune disease. So you have a lot of auto antibodies like attacking the thyroid, and this happens in iodine sufficient areas. So it can result in enlarged goiter. What is really like weird, or not weird, like it's not really specific, that most of these patients present with euthyroidism, so they are hard to pick up until there is a goiter. Why they present with euthyroidism? So what happened is, so you have a lot of these antibody attacking the thyroid. So, and there's a lot of, so these thyroid follicles producing T3 and T4, so they are functioning thyroid. And then after at the first, so when they are attacking the follicles, these stored hormones at first they get secreted. So that's why sometimes you have even transient hyperthyroidism in this kind of disease. And then afterward, like when time passes, so these autoantibodies start even attacking more and more and more, and like make a destruction of these thyroid follicle. So when they make a wide range, like a very widespread destruction, what happened is, so this thyroid keeps secreting the thyroid hormones. Some of it stops secreting, so it results in euthyroid, like euthyroid status, which is not hyperthyroidism, not hypothyroidism. And but because this process making that thyroid is really inflamed and it's just trying to fight itself, these it results in forming this kind of reaction, which is a plasmacytic reaction. And even like these inflammation can be very, very distinct, that they can produce like a germinal center, like you can see it in like a proper lymph node. So and they start eating up or make like a destruction of these follicles. So you can see here that the follicles are very nice, large, they have like different sizes. Here you can see like they're becoming more and more like smaller. Some of them, they don't have actually like a distinct borders, just like the lymphocytes or the plasma cells are just infiltrating in between. So these are the features of Hashimoto thyroiditis. So, on microscopy, you can see lymphoid follicles with germinal centers, Hertel cells, which we will discuss later, and fibrosis. So, when these cells or follicles die, after just after like a period of time, they become fibrotic. So, there is an increased risk of lymphoma in these kind of diseases in longer-standing cases. So this is like any kind of like thyroid nodule. When you present with a goiter, the same thing, you will do like a thyroid function test just to make sure like where do you go from there? Like, is it a hypothyroidism? Is it a hyperthyroidism? And what is more specific about this entity is the antithyroid antibody levels. You would do ultrasound neck and if needed, fine needle aspiration. So that's the like the hard thing about diagnosing Hashimoto, that they're the presenting, like the presentation can be very very different. So it can present with hyperthyroidism, as I said, or it can present with normal or low serum thyroid hormones. It depends on what stage of the disease the patient presented. And there is also like the elevated serum antithyroid antibody. So why these kind of, like, why do we see these kind of diseases? Like, you would think that, okay, so there's like a specific antibodies, why don't they just do the antibodies, and if they are elevated, that's it, why do they take it out and send it to pathology? So what happens is most of these patients get referred to ultrasound, and sometimes the radiologists see some kind of like thinking maybe this can be a solid lesion which they are worried about, so they prefer to send it to histology. Sometimes we just take like the FNA and then we say, okay, so that's reassuring. Sometimes the FNA, even like the specimen, can be inconclusive, so we're not really sure if this is just like a benign lesion or it might be a neoplastic in origin. So we advise that you might need to have to remove the like part of the thyroid to make a diagnosis. So that's normal thyroid. So keep that in mind because I want to show you the abnormal ones. So you can see here that they are like a smooth surface. They look very regular, like you can't see any like nodularity. I know that this like not a very nice picture regarding to the color, but other than that, it differs than the disease thyroid. So let's see this thyroid. So what it looks very nodular, like you can see that these, it doesn't look very smooth and uh, very homogeneous. It looks very nodular here. It looks very like tan, yellow colored. It looks very flushy, if that makes sense. It doesn't look good. And of course, it is enlarged. So we said that one of the features is Hertel cell exchange. So you can see here in this picture, this is a beautiful lymphoid follicle, and here this is the germinal center, which is the balar area of the lymphoid follicle, and you can see here that these are the thyroid follicles, and they're becoming like small, just like there's not a lot of variation, there's not like there's no a lot of like macro follicles and micro follicles. And you can see here the cells themselves, they look more pinkish, they don't look like, okay, so this is a closer look, so they are pinkish. The nucleus itself looks very vesicular with the prominent nucleoli. The cytoplasm is granular, like you can see, like it's very dense, and this is the normal one, just to compare. So you can see here that this is a very nice cuboidal small cells. The cytoplasm is pale, and here look how the cytoplasm differs. So this is what we call like the Hertel cell change, which is one of the features of Hashimoto thyroiditis. Yeah. Okay, let's go to case number two. Oh, sorry, let me see if there's any of the questions. Okay, lots of inflammatory cells, yeah. Could this shrinkage be due to the swelling of the thyroid? I don't understand, sorry. If you can clarify, what shrinkage do you mean about? Uh, yeah. So let's go to, if you go to case number two, if there's anything that you want to ask about before going to case number two, you're more than welcome. Yeah. So, case number two, a 30-year-old woman post-thyroidectomy for hyperthyroidism shows follicles with tall epithelium and scalloped colloid. I'm just gonna wait for a few minutes. If you wanna pop anything in the chat box, that would be amazing. Okay, it's okay. So, this is the thing that we discussed in the one of your colleagues asked about, which was very smart. Is the scalloping? This is the scalloping of the colloid, which means that there's like this whitish area. It's not very smooth and clear, which means that the thyroid is very active. Yes, exactly. It's a Graves' disease. Graves' disease. So what's okay, so this is what Graves' disease looks like on macroscopically. So you can see that the thyroid is enlarged, and they have this look, which they describe it as a beefy cut surface. So it looks like a raw beef. It's very dull, and like the color is brownish to it's really like dull, and it looks like a beef, to be honest. Yeah. So what happened is in Graves' disease, let's go back to the normal just to compare. Okay, so this is the normal again, and this is the abnormal or Graves' disease. What you can see here, the difference is, so you can see here that they are nice and round. Here you can see that there's like a papillary projection, like they have like ragged outline. It's not very smooth, and it's not very circular anymore. Yes, it looks like a steak. So, and you can see here even the nucleus. It doesn't look the same as this nice and round and blue nucleus. Here, this is the exact picture of scalloping. Okay, and I have also like the scallop here. So it's like, I don't know how it's I don't know how to describe it, but it's like ragged and not really uniform, and have this kind of like a scalloping appearance. And as I say that, so there is like a papillary projection here. So what happens in Graves' disease is there is like it is also an autoimmune process. There is an autoimmune stimulation of the TSH receptor. So it's like the TSH receptor, the thyroid is just like working all the time. So what happened is there's like a diffuse hyperplasia, and the patients present with hyperthyroidism, diffuse goiter, and exophthalmos as well. On histology, as we said, so there would be like a tall columnar epithelium, scalloped colloid, and papillary enfolding. I'm just going to show you the epithelium again. So it's so if you can see here, we said that this is like a cuboidal, and you have the nucleus in the center. But here it becomes more columnar. If I can convince you that this looks like a bit columnar, and the nucleus is a bit on the basal side. Why is the colloid darker? Oh, sorry. So sometimes the staining differs. So it's nothing like to be very alarmed about. It's just like depending on the lab or the picture from the websites, different website, but it's not something that you should be worried about. The most important things are these empty spaces or the scalloping look to it. So you can see here also it's abnormal and just the colloid looks all right. Like I mean the color. Okay, so yeah, we said that papillary enfolding, and this is the exophthalmos. Case number 3. So enlarged thyroid replaced by multiple colloid-filled nodules with old hemorrhage and fibrosis. Okay, so this is the multinodular goiter, which is the most common disease of the thyroid gland. And it has multiple names. It has the new name is the thyroid follicular nodular disease. The more clinical name is the multinodular goiter, which means the same thing. What happened is, so there is like a recurrent episodes of hyperplasia and involution. So that's why you would see a wide range of like clues that this is a multinodular goiter. First of all, this patient that presents also with euthyroid, but they can have compression symptoms because it can be very, very large and compressing other structures like the trachea, the esophagus. On microscopically, so you can see a variable size follicles, colloid, fibrosis, and cystic degeneration. So we're just gonna go more about these. So what happened is that these, if you remember, I think I put the normal one here. So this is the normal. Just keep it in mind. So as we said, like macro follicles. Here you can see that these follicles are becoming too enlarged, which what we call like it is a cystic enlargement or macro follicles. Even the cells that like the follicular cells becoming very flattened. If you can see here that it's very flattened, and you can see here that there is different, it's also like there's a different sizes, but the striking is how large can the follicle be. So that's why even it can have like a follicular nodule it by itself. But we don't, because it's not alone and it's not like partially encapsulated. We say that this is a part of the same process of the same disease. So you have to look at this disease by like a holistic approach, or you have to see everything and then call it. You don't rely on one thing, because if you remember, if you can see like only this area, you would say maybe it's normal. But if you see like hemorrhage, if you see a lot of fibrosis, if you see a lot of cystically dilated or colloid nodule, that all these, and you can see like clinically that the patient have a very, very enlarged thyroid. All these can give you the information that this patient might have multinodular goiter. um, so there is a 3 to 5% risk of thyroid cancer, predominantly follicular variant of papillary thyroid carcinoma. Uh, yeah, so this is the normal again. This one is a bit dramatic, but it can have a very enlarged thyroid. You can see here that this is very, like, it is really compressing like all these structures. Okay, so case number 4. An encapsulated follicular pattern lesion with the tumor cells showing oval nuclei with mild nuclear atypia, but neither chromatin clearing nor nuclear pseudo-inclusion and no capsular or vascular invasion. So this is, if you can see here, there's some kind of like a capsule here. And this is the picture. So you can see here that there is like a distinct entity here, and this is the normal thyroid. So this is what we call follicular adenoma. So follicular adenoma, it's a benign encapsulated tumor of the follicular cells. So if you can see here the capsule, so this capsule is thin, but it has blood vessels. In other areas and other diseases, the capsule itself can be very like distinct and very dense or widened. So benign encapsulated tumor, the most important thing with follicular adenoma, and it's really important to distinguish follicular adenoma from follicular carcinoma, is the capsular or vesicular invasion. So if you have capsular or vesicular invasion, this is follicular carcinoma, not follicular adenoma. So what I mean is, if you have any of these um, um, like follicles are just like budding through the capsule and going out like a mushroom, this is a follicular carcinoma, not adenoma. And if you have any of the blood vessels having thyroid follicles inside them, this is also thyroid carcinoma. Usually present non-functional thyroid, also euthyroidism, as solitary cold nodule on microscopy. So the cells are cuboidal with round, basally located nuclei, smooth nuclear contour, and uniform chromatin. So this is really important to look at. So this is the thyroid adenoma. It's really important to appreciate the nucleus itself, because in other entity, the nuclear feature would be very striking. So here you can see that the nucleus is blue, small. It doesn't have a distinct features. um, Here, this is the normal one. So just to differentiate between the normal one and the follicular adenoma. So if you can see here, this nucleus is a bit darker, is a bit, yeah, basally located, but overall there is no striking features that might uh, might let you think that this might be something like papillary thyroid carcinoma. So that's a really nice picture of a thyroid follicular adenoma. So you can see here that it is a very well circumscribed. Like you can see that this is a very homogeneous looking tan colored cut surface. Let's go to this question. So, which of the following are important criteria used to distinguish between benign from malignant thyroid follicular tumors, which lack the nuclear features of papillary carcinoma? Uh, B, which is the nodular edge. I see why this can be confusing, but the answer is, oh, sorry. I think it's the right answer. No, no, no. Vascular. No, it's the vascular invasion. Yeah, but I can see why you might go for this one. So the nodular edge. So it has to be, that's the like the distinct thing about thyroid follicular carcinoma with adenoma, because even like, I'm just gonna go through this one. So the edge of the nodular edge, so if the budding, it has to go all through the capsule, so we can consider it as thyroid or follicular carcinoma. So even if you have these kind of things here in the capsule, you can't consider it as a follicular carcinoma. You just still say that this is follicular adenoma. So but I can see why you go for this one, because it's really confusing. Yeah. So even like this one, so let's go through this picture. So this is, let's say that this is a follicular adenoma. and there is a budding here, but it's inside the capsule. So if it is still inside, we can say that this is only follicular adenoma. Now this one is budding outside, so this is follicular carcinoma. This one is budding outside and taking the capsule with it. Also, this is a follicular carcinoma. This one is completely outside the capsule, which is a follicular carcinoma. Here it's inside the capsule, not yet. Here it's inside the capsule, not yet. Here it's outside, so yeah. And here it's budding, but it's inside also, so not yet. Also here there's like a um, micro follicles, but not yet. So that's really like you have to be very thorough looking at the capsule. Like even a lot of the places they take like an extra opinion for this kind of thing, because it can be very confusing to know where is exactly like the capsule, and where is it budding, or is it just on the capsule. Okay, so that's a really nice question. Like bionuclear features of papillary carcinoma, what do you mean? So we're going to discuss it later in details, but the papillary thyroid carcinoma has a distinct nuclear features. It means that the nucleus itself can be a glass appearance, like the chromatin is very clear. It can have like nuclear grooves. It can have pseudo occlusions, but I have like more pictures that you would like understand more with the pictures. So follicular carcinoma, malignant counterpart of follicular adenoma. So the most important thing is this point, and I can't like focus on it enough. It's the capsular or vascular invasion. So this is the diagnostic. It's spread to the bone, hematogenously to the bone and the liver and lung. Unfortunately, that 69 percent of the patient have distant metastasis, which is um, not really a good thing. The most important thing is no papillary nuclear features, because there is like an entity, but I'm not going to discuss it because it's really advanced. So, and I don't want you to get confused. There is a follicular variant of papillary thyroid carcinoma, which means that the lesion, so it has the architecture of follicular carcinoma, but the nuclear features looks like papillary thyroid carcinoma. So this is we treat it, and we consider it as papillary thyroid carcinoma, not follicular carcinoma. So risk factor is insufficient iodine or ionizing radiation. But the thing is, in recent study, they're saying that the radiation is not really a factor. So it's really controversial in follicular carcinoma. So this is what we were saying about the capsular invasion. So it looks like a mushroom budding through the capsule. And if you can see here that this is the capsule, yeah, and it's budding and it's taking the capsule with it. But this is still considered, you might argue that the cancer is still here, like it's not going outside. But if this kind of budding where like it taking the capsule with it, so this is also like follicular carcinoma. This is a nice picture of also follicular carcinoma on macroscopically. So you can see here, if you squint your eyes, that there is like a thin fibrous capsule here, and there's something budding here. And you can see the counterpart of like the histological picture, where you can see here the tumor is budding outside, and this is like the fibrous band or the fibrous capsule is right here, and this is the tumor. And that's a picture of vascular invasion. What it means is this is like obviously a vessel, there's a blood cells in it. This is the tumor, and you can see here that these are follicular cells inside the blood vessel, which means that this is already follicular carcinoma. And that's also another of the capsular invasion. So this is the capsule, and it's just budding outside. Okay, I think this is the last case. 26-year-old woman with painless thyroid nodule and a cervical lymph node metastasis. Histology show papillary fronts with fibrovascular cores, optically clear nuclei, grooves, and semomo bodies. I'm sorry, just one sec. So what do you think this is? So this is papillary thyroid carcinoma, and we're going to discuss the nuclear features more. So these are, if you can see here, the nucleus is a bit weird looking, like it's a glassy appearance, like it's very clear. It's like you can see through it. If you can see here that there's like a circular thing inside, which what we call like a pseudo inclusion. If you can see also, I'm just looking for the grooves. No, there is no grooves here. Yes, here is a better one. So if you can see here that there is like a coffee bean shaped nucleus, like there's a groove in here. Here also, when you see it, you can't just unsee it. Here, here as well. And let's look for inclusions. Is there any inclusions? I don't think so in this picture. But you can see here that this is like a ground glass appearance. And also like the nucleus themselves, they very large. They are overlapping. They have like this chromatin clearing. And they always like say the orphan Annie eyes. So this is the famous orphan Annie. And it's really like frightening. I don't know why they have like no pupils anyway. So this is a picture, nice picture of papillary. So what does papillary actually mean? Like these projections, they are papillary shaped, and they have vascular core in between. These, if you can see here, the vascular cores. And what you can see here, which is, they always like mention it, but it's not very specific for a papillary thyroid carcinoma. But it's nice. I think more than 50% of the times you can see it. It's the semomo bodies, which is the calcification here. But I have a better picture for semomo bodies, I think. Yes, here. So they are saying that this is like onion skinning, or like it's really layered here. Here you can see as well. Okay, so papillary thyroid carcinoma, it's the most common thyroid malignancy. And it's really good that it is the most common thyroid malignancy because the survival rate is very high. So most of the patients, unfortunately, they present with lymphatic spread, but it's okay because it's even doesn't affect the survival. So that's really good. Histology, you can see papillae with fibrovascular cores, orphan Annie. What did I say? I said something else. Okay, orphan Annie nuclei, grooves, and semomo bodies. A change of the nuclear size and shape, nuclear enlargement, elongation, and overlapping. And there's the chromatin features, which is the chromatin clearing, margination, and glassy nuclei. Nuclear membrane irregularity, which is like the nuclear itself can be like have irregular contour, nuclear grooves, and nuclear pseudo inclusion. So the most important cause is this. This is really associated with ionizing radiation before the age of 20, and they have discovered that post Chernobyl incident, what happened is one in actually four cases which were diagnosed with thyroid cancer, they were due to this incident. So one in four, they resulted in papillary thyroid carcinoma, which is a very big number, especially if they are children's. Also, Hashimoto thyroiditis might be associated, but it's not really conclusive. And there is also LFAB, and it can be familial in 4.5% of the diseases. Overall, very excellent prognosis with a very, even like the life expectancy can be similar to general population, which is very good. So you can see here that this looks very different like from any of the things that we saw before. So this is a like it looks very irregular. There's like hemorrhagic areas inside. It looks very firm. It looks very whitish. It looks solid. So this is what papillary thyroid carcinoma look on. And there's also like cystic areas on. So there is like it's a very variegated appearance. Okay, that's it. Thank you so much. I'm sorry for keeping you for that long. And if you don't mind doing the feedback form, that would be amazing. So I'll just keep it for a while. And if, of course, if you have any question, please feel free to ask.
Hi, Dania.
Yeah.
Hi, thank you very much for such an interesting talk. It's quite funny to hear about all the different ways people describe cells, like the eyes as well.
Yeah.
So thank you for that. I've also put a feedback form in the group chat
Okay.
for the messages. So if anyone wants to fill in the form, you'll get a registered attendance form for this, which is quite useful for your portfolio. And we can also forward on any feedback to Dania as well, which will be very useful as well. So please fill that in. Also, just to highlight, we've got another talk next Monday from 7 to 8. And that's on GI pathology. So please do come along as well for more further histopathology tidbits. So please come along. And thank you.
Thank you so
Thank you
much.
again,
Thank you
Dania.
so much.
Thank you.
Thank you, guys. Bye.
I'll end the stream now if
Okay,
that's
cool.
okay.
Yeah. Thank you so much.
Thank you.
Bye.